Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenter is Dr. Amir Dastgah. Dr. Dastgah is a podiatrist.
Going to talk about diabetic foot diseases and disorders. And basically, when you look at this diagram, diabetes doesn't just affect the feet, it affects the kidneys, lower extremity, the nerves, the heart, the eyes, and everybody gets affected, famous people, even the famous people. Thomas Edison, Theresa May, Tom Hanks, Larry King, Salma Hayek, Halle Berry, Sharon Stone, and Nick Jonas. If you know any of these guys, that's good. Worldwide, diabetes affects 114 million people in China, and China just recently surpassed India in the number of diabetic patients. So in India, we have right now about 62 million people with diabetes. And when you have a diabetic foot ulcer or diabetic foot problem, it basically causes you to have severe problems and cost the medical system a lot of money. And usually it involves a primary care doctor, a podiatrist, nephrologist, a radiologist, podiatrist, and many social workers, nurses. And I'm trying to, what I'll do today is talk about a few things that we could do as diabetic patients to prevent, hospitalization, amputation. So diabetic pathophysiology, as far as the diabetes goes, is a metabolic derangement. So you have a high blood sugar and low insulin levels, and then your immune system is compromised, right? So just like HIV or other immune diseases, your immune system is compromised due to high blood sugar and many other factors. That's one problem. The other one is the neuropathy, diabetic peripheral neuropathy, which means that you have one or many of them, most of the time, all three of them, the motor sensory neuropathy, motor, sensory, and autonomic neuropathy, sorry. And then you have angiopathy, which means poor blood circulation. And then you got mechanical stress to the affected area, bony prominences like a bunion deformity, TAILOR'S bunion deformity, high arch or low arch, pressure points in the foot and ankle with callus manifestation. The other problem we have is either the patient neglects their diabetes or the provider neglects, or both. The new CDC says more than 100 million adult Americans are either diabetic or pre-diabetic. That's a big number. And 60% of all the lower extremity amputations are performed on diabetics. The more proximal amputation you need more expenditure, you need more energy to walk, and there's more problem to that. So like losing a toe versus a below the knee amputation, which one do you think needs more energy to walk, right? It's not just like psychological effect that you have with the amputation, but it's also the amount of energy you need to walk, right? If you have a below the knee amputation versus a big toe amputation, it's a big significant factor. Cellulitis occurs about 9 times more frequently in diabetics. Cellulitis, is a skin infection, superficial skin infection. And it could mimic, I'll go more into this. It's not only the cellulitis that we are worried, there's other things. I'll just talk about sensory neuropathy. So loss of sensation, basically, you cannot feel your feet. That's one problem that diabetics get sooner or later, okay? And then If any of you guys were at the front and had any diabetic foot exam, we always use a vibratory sensation, use and a monofilament to examine your feet, right? Or your podiatrist, or your Dr. Kata, or any primary care doctor. Basically, the monofilament is like a fishing rod that applies about 10 grams of pressure to your feet. Okay, that 10 grams of pressure mimics a little pebble in your shoes. Usually, as a diabetic patient, later on with your diabetes, usually about more than 5 to 10 years, you lose that protective threshold. So if, God forbid, there's a pebble in your shoes, you will not notice, right? You walk on that pebble without knowing. I had a patient come into my office with his daughter, and the daughter said, "Dad, have a seat." He sat down, he's like, "Dad, take your shoes off." So he took his shoes off, and I'm not kidding you, he had a kiwi on tip of his toe. So I thought he was joking with me. I said, "You got a kiwi on your toe," and he had the white socks, and he couldn't see that well. He's like, "Oh, I didn't feel that." And the story is, he had the kiwi in his hand, and his daughter called and said, "Dad, oh, you're in the front, I'm about to pick you up," because she didn't live with him. So he would get panicked, and somehow the kiwi fell into his shoe. And then he put his foot in the shoe and then comes to my office. The kiwi was sticking to his toe, and I was looking at him and I was thinking, he's probably kidding with me. And he was like, "No, I did not feel it." That's really the late stages of diabetes. That's a sensory neuropathy. 25 to 50% of diabetic foot infections lead to minor amputations. 10 to 40% require major amputation. That's the below the knee amputation, above the knee amputation. And 10% to 30% of patients with diabetic foot ulcer will go on to amputations. These are just the statistics that I kind of provide for you. The motor neuropathy is another problem that diabetics may face, and motor neuropathy is basically the nerves that innervate your nerve, the muscles in your feet, they get affected. And because of that, in your feet, you could have hammer toes, claw toes, mallet toes. If you have a high arch or low arch, those they become more exacerbated. So somebody with a higher arch might have like a bad hammertoe deformity, and then now the deformity worsens after the onset of diabetes or a few years after that. This is a hammertoe deformity, and this patient might not be diabetic, but this, if you look at it, if you look right here, that's where the pressure point is, right? So where do you think the patient could get an ulceration if they wear a tight shoe, right? This is a mallet toe deformity. So the deformity is a joint distal to the previous one, the hammertoe, that is at the distal interphalangeal joint. This is the bunion deformity. So the pressure point, as you see with the red area, that's where the pressure points are. There's a lot of times the patient has bunion deformity, but then at the same time, they're wearing tight shoes and they're diabetic and they don't feel that pre-ulcerative lesion. And then eventually it becomes a full-blown ulceration and possible infection. So if you have something like this, or a hammertoe deformity or a mallet toe deformity, probably want to fix those if they become ulcerated, or maybe be a little bit more aggressive and fix it before it causes you to have diabetic ulcerations. This is a Taylor's bunion deformity. The reason they call it a Taylor's bunion, because before, back in old days, the tailors used to press the pedal on the floor, and they developed that. So that's why we call it a Taylor's bunion. This is a flat foot deformity. So as you see, most of the pressure points will be on the medial side of the foot. So it would be right around here, right? On the inside of your foot or your feet. This is somebody with a high arch foot, right? This is called a pes cavus deformity, basically on the ball of their feet. It's called a tripod foot. And this is a diabetic foot ulcer due to a hammertoe deformity, right? And usually you get a hammertoe deformity that is flexible initially, and then it becomes semi-rigid to a rigid. When it becomes rigid into a hard callus, and then distally on the tip of the toe, you could develop this ulceration. And then if, let's say, you have this and you don't cover the wound in a shower, that's how you get a bone infection, or you end up in a hospital because, the shower is not the cleanest part. A lot of times I ask the patients, you have this wound, have you been covering it in a shower? They look, no, I have not been covering it. I just washed it in a shower. Well, now you get infection that goes to your bone and proximally, right? That's how you lose limbs. This is another patient with an ulceration on the bottom of their foot, and that's probably due to a cavus deformity, that high arch patient that we talked about. One other problem that even emergency rooms or urgent cares a lot of times miss is when patients go into the hospital or urgent care and with a red swollen foot, it hurts, and the doctor says, I think you got cellulitis, take this antibiotics and you should be fine. A few days later, the patient comes to the podiatrist and, doc, my foot hurts really bad. And then you take x-rays and you see that this patient has something called Charcot arthropathy. And what that is basically diabetes working and causing sensory neuropathy. So this patient didn't feel anything. The joints disarticulated. The autonomic neuropathy increased the blood flow to the foot, right? And by doing that, it washes away the joints and the bone, and you get disarticulation of the joints. And then you develop ulcerations. One way to find out is educate even the emergency medicine doctors and primary care doctors that, to inspect patients' feet and also check the temperature. You see, if you look at it here, it basically tells you that this patient had Charcot arthropathy, was placed in a total contact cast, and then later on the temperature decreased. So they were basically immobilized in a total contact cast. Now you got crow walkers or can walker boots, but basically when you have this deformity, and you should initially be placed in a can walker boot, get a knee scooter, and don't apply any pressure if you can. If you can't, then maybe just walk with the boot, because there will be less destruction at that time than if you walk on it, okay? This is the Charcot foot we're talking about. It doesn't only affect the diabetic patients, it affects anybody with neuropathy. So it could be diabetic neuropathy, it could be alcoholic neuropathy, it could be due to syphilis, any of this, basically. And usually it is non-painful until the joint disarticulates and you get this deep aching pain. That's when they notice it. But at that time, it might be a little bit late, at least for this patient to be offloaded. I just saw somebody at Washington Hospital. He had come in probably in his 50s with diabetes, went in, it was initially diagnosed as cellulitis, was placed on antibiotic, IV antibiotics, and then they took x-rays, luckily, and they found that he had Charcot arthropathy. And then, the treatment is totally different. So you got cellulitis, which is a skin infection, versus this has nothing to do with the infection. It's basically disarticulation of your joint due to diabetes. And these are basically classification of diabetes and where the diabetes could affect. So right here, it affects along the metatarsophalangeal joint. This is at the Lisfranc joint. This is at the talonavicular joint, and this is at the ankle joint. So it could affect any joints in your foot and ankle. And this is the Charcot foot that has affected the metatarsophalangeal joint. Okay, so the next picture you see, this is probably somebody with Charcot foot at the first metatarsophalangeal joint. As you see, the joint has been disarticulated and the bone has been washed away. That's because of the Charcot foot. And as you see, the whole Lisfranc joint has collapsed, and instead of the bones being on top, they all collapse and they're down here. So, and then you have lost the alignment of your foot. And these people require a major reconstructive surgery, hospitalization, and skilled nursing facility, a lot of care. So for conservative care as far as the Charcot arthropathy goes, and Charcot arthropathy, we could basically initially put them in a cam walker boot or a crow walker, which you have to go and get from a prosthetic company, and they basically mold your, cast your feet, and they make that. This takes probably about a month to get sometimes. So until then, you probably need to wear one of those ski boots, right? And then later on, you get that. This is if somebody doesn't want to go to the surgical route, right, and have this corrected. But if this is a Charcot foot, a Charcot ankle, and that's very complex problem, and then they end up with something like this, where you have like external fixation and long time immobilization and a lot of surgeries. So the autonomic neuropathy is basically what causes anybody that has diabetes to have dry skin, right? Lose hair follicles from their skin. And then it causes other problems that the other doctors probably talk to you about. I'll talk about pressure sores. Now, if you have diabetes and you're basically older and you're sedentary, you're either at home, sitting in bed, if you have any family members, you want to offload their heel, right? If they're sitting in the bed or on a couch or in a wheelchair, if you transfer them around, you want to prevent pressure sores. But this could be also because of a diabetic foot ulcer that happened at the heel. They stepped on something. This is pressure sores that develop throughout the body because this person is probably laying down in a bed or in a wheelchair. A lot of times I see patients come to my office and the family brings them in with just either bare skin, no socks or shoes, and they're stepping on that foot pedal, metallic foot pedal or plastic foot pedal. And then if you see something like that, you probably want to wear your diabetic shoes and have well padded socks. So stop pressure sores. These are ischemic ulcer. That's another problem that diabetic patients get due to ischemia, which means poor circulation. So what you want to do, establish a relationship with your primary care doctor and also see a vascular doctor. I encourage your primary care doctor, maybe have some circulation tests done, either at the hospital or just establish a baseline care with a vascular doctor. So this is an ischemic source, ischemic ulceration due to poor circulation and diabetes. Somebody that smoked, gangrenous toes. So what should we do? Inspect your feet, wear diabetic socks, moisturize your skin, and then see a podiatrist if you can, and then find out where you are with your neuropathy. Is it mild loss of sensation? Is it very severe? If you have any wounds, cover your wounds and then seek immediate help. Any ingrown toenails, calluses, please try not to trim them yourself. See a podiatrist, or at least talk to your primary care doctor and see what they want you to do. Always ask primary care doctors. And then this is a diabetic insole. Basically, it's a plastizoid with multi-level padding. The bottom layer is basically a support, arch support. The top two layers are just cushioning, and it prevents diabetic foot ulceration. And you'd be surprised how many amputation you prevent just wearing your diabetic shoes and wearing the diabetic insoles. Now, most patients that are neuropathic, we as a podiatrist, I'll give a prescription to them, and then they contact Dr. Kata or the primary care doctor, and then they have to submit their notes to the prosthetic company, hangers if they are a private patient, and the Medicare, they go to a Hallis pharmacy. Some of these are custom made because of the foot deformity, but if you don't have any deformities like pressure points, callus formation, you could just get the heat moldable insoles, which means is basically something that you pick up from, they give you off the shelf, is over the counter, okay, versus something that they need to cast you. These are the diabetic shoes. Most places, prosthetic companies have these diabetic shoes that you could pick and choose based on your taste, where they're not, a lot of times I tell patients, hey, you know, you should get a diabetic shoes, but they're ugly, I don't want to wear them. I'm like, well, they used to be ugly maybe, but at this time you could go to Dr. Comfort or a lot of websites that have very nice shoes. They're seamless, they don't have any way to cause you any sores or pressure points. And you know what, if somebody is getting the diabetic shoes, probably when you go to get measured for your feet, make sure they measure your feet while you're standing. A lot of times I've seen they come in and they have their diabetic shoes and they still having an ulceration in the tip of their toes. And I'm like, did they measure your feet while you were standing or sitting? And they're like, no, I was sitting. I was like, no, that's not how it's supposed to be done. They should measure you while you're standing, right? And then also measure the width of your feet. And then if anybody is tech savvy, I guess they got these socks now. There's 2 or 3 companies that develop socks with sensors on the bottom of the, the socks. This one I think is called Siren in particular, and it measures a temperature in your feet. So if you get acute inflammation due to a pre-ulcerative lesion, it detects it and it sends it to your cell phone app if you have an iPhone or Android. And then the sensor is, as you see right there. This is actually a local company in San Francisco, a young lady that developed this. This is the other one that detects the pressure. Increased pressure points, as you see right there, are detected on these socks and then sent to your cell phone. And then at that time, you probably need to see a podiatrist or a podiatrist and have them offload your foot around that area. So last few words, see your primary care doctor, endocrinologist, podiatrist, vascular surgeon, eye doctor, kidney doctor, orthopedic surgeons if you have any knee or hip pain, back pain. Treat painful deformities in your feet, such as bunion and hammertoes and flat feet. Avoid treating yourself. One big problem, I give you a little story. I was in residency first year, and I remember this gentleman that kept coming in. He was selling wholesaler for a big company that was selling fruits to Staten Island and New York, the 5 boroughs. And he was very busy, and he would come in every 2-3 months and get these calluses debrided so he doesn't get an ulceration. But at one point he decided, because his mother told him to get one of these corn and callus removers from CVS and just apply it to the area where he had the callus formation, and this would be removed. So he had applied this salicylic acid, which is an acid, from Dr. Schultz, and he never read the package insert which said, do not treat your calluses if you're diabetic. So he had this major foot infection, and he ended up in a hospital and lost like his 5th toe, and cost him a lot. So if you're diabetic, do not treat yourself. I mean, do not use this salicylic acid, wart removers. Seek immediate help. See your podiatrist, see your primary care doctor, your endocrinologist. They will always lead you to the right direction. And then if you, God forbid, have any wounds, please contact us at Washington Hospital Wound Care Center, and then encourage your primary care doctor to have you come in there earlier than later, right? Because a lot of times we see wounds that have been treated by primary care doctor, urgent care centers for a month or 2, and then when they don't see any improvement, they send you to us, and at that time we still could treat you, but there was some underlying problem that was not addressed. All right, thank you.